Welcome to Evolving the Management of Multiple Myeloma, presented by the Albert Einstein College of Medicine of Yeshiva University at OMed Live. You are tuned in to today's first session titled Integrating New Therapies into the Treatment of Newly Diagnosed Multiple Myeloma. My name is Dr. Ken Anderson, and I'm the Kraft Family Professor of Medicine at Harvard Medical School. I'm pleased to serve as the Activity Director for this important educational program. Today's session is a live interactive program that allows us to take questions in real time throughout this presentation. So I therefore encourage you to please send us your questions anytime by typing them in the box located at the lower left-hand side of your screen. I'd now like to introduce our first faculty member, Dr. Philip Mccarthy. He is the Professor of Oncology and Director of the Blood and Marrow Transplantation at Roswell Park Cancer Institute. Phil, thank you very much for joining us today. I'll now hand the program over to you to begin our discussion.
Thank you, Ken. These are my disclosures. I've done consultancy for Celgene, Janssen, Millennium, and Sanofi. And my talk today is going to be the evolving management of multiple myeloma. This is where I work at Roswell Park Cancer Institute in Buffalo, New York. And I'm starting with a slightly older slide, but it still holds applicability to today's myeloma therapy. On the left, you see IMiDs, the immune modulatory drugs. These have become a mainstay for the treatment of the newly diagnosed and the relapsed refractory myeloma patient, as well as the proteasome inhibitors, here demonstrated by bortezomib. They have multiple effects on transcription, caspase, pathways, and of course the proteasome inhibitor. There are other targets in the myeloma cell, such as the AKT pathway, mTOR. The heat shock proteins are now being utilized in clinical trial. HDAC inhibitors are further along. There was a panobinostat study presented at ASCO this year. And of course, alkylators still remain a mainstay of therapy, both cyclophosphamide and melphalan in particular. This is a timeline adapted from Dr. Anderson's talk at ASCO in 2011. Our first effective therapy was back in the 60s, oral melphalan and prednisone. Then the development of high-dose melphalan, followed by VAD, vincristine, adriamycin, dexamethasone, autologous transplant, and then into the 80s when we had the development of, or use generally of high-dose dexamethasone, the use of bisphosphonates, as well as autologous peripheral blood stem cell transplant. And the big breakthroughs occurred with the development of the IMiDs, first the thalidomide, then lenalidomide, followed now by pomalidomide, and the proteasome inhibitors, bortezomib, soon afterwards, followed now by carfilzomib, and currently in clinical trial, aprocimab and ixazomib. What's really exciting is the development of monoclonal antibodies, in particular elotuzumab, and the anti-CD38 antibodies daratumumab and the Sanofi drug, as well as others in clinical trial. And the HDAC inhibitors, as I mentioned, panobinostat was talked about recently, or was presented recently at ASCO and combined with bortezomib. So we have a lot of new agents that Dr. Anderson will be talking about in the next presentation. And we have a variety of new technologies to help us determine whether or not a patient who has smoldering myeloma will progress to full-blown myeloma requiring therapy, and will also help us establish risk. In other words, how well will a patient do once they require therapy? We initially started with G-banding or metaphase karyotyping, but the big advance was FISH, fluorescence in situ hybridization. There's now gene expression profiling, as well as combining all these molecular tests to look at global gene mapping, methylation, and then eventually next generation sequencing, which will allow us to be able to determine which clone has developed at diagnosis and which clones develop subsequently at disease relapse. So this is the IMWG diagnostic criteria for smoldering multiple myeloma. And this is first developed in 2010, and then it's been changed, and you can see it in the NCCN guidelines where they give criteria for smoldering, as well as some of the criteria that we should be thinking about when it comes to treatment. For the serum monoclonal protein, it should be greater than 3 grams per deciliter for IgG and greater than 1 gram per deciliter for IgA. or Bence-Jones proteinuria of greater than a gram per 24 hours, and there should be clonal plasma cells of greater than 10%, and there should be no end-organ damage. I borrowed this slide from Dr. Ola Lundgren, and this is comparing the Mayo Clinic criteria for smoldering myeloma and the Spanish criteria on the right. And you'll notice for the Mayo criteria, it's greater than 10% plasma cells, the IgG greater than 3, and a very abnormal serum-free light chain ratio, whereas the Spanish criteria are 2, greater than 90% abnormal plasma cells within the plasma cell population, and immunoparesis, in other words, immune dysfunction. And high-risk patients who have the highest number of risk factors have a very short median time to progression, less than 2 years, 2 full-blown multiple myeloma. And this was just proposed, this was in Blood from 2013, a new way of potentially reclassifying smoldering myeloma. It remains to be validated in future studies, but these are patients without CRAB criteria, small numbers of plasma cells on the right. They're considered high-risk MGUS, and they're observed. If they have greater than 10% plasma cells, and in the middle a very abnormal serum-free light chain ratio, and more than one focal lesion on whole-body MRI, these would be considered also smoldering myeloma, and they should go on to therapy according to this proposal, depending on what criteria they have. For patients who have greater than 60% plasma cells, they're essentially developing active myeloma, and those are a little bit different. But this all remains to be validated as a new approach to potentially treating patients early on in the course of their disease. And this is why we do have some issues, though. This is, again, Ola Lundgren's group. But what he did was he took his own patients and then used both Mayo and Spanish criteria, and he found that the overall agreement was only about 29%. So our concern is that depending on which model you use, you may be offering your patients something that the other model would say is not necessary. And as you can see here, that there's only a small concordance between low, medium, and high by Mayo, and the same with the Spanish criteria. So a lot of this has to be ironed out, and we have to get together so that we can develop criteria that we can all agree on and that we all will be able to show has clinical utility. Now, this is the trial from the Spanish group, Mateos et al., NEJM in 2013. This was a fairly simple trial for high-risk smoldering patients who are either randomized to observation versus lenalidomide and dexamethasone for 9 cycles, followed by lenalidomide for 2 years maintenance. The overall survival is on the left. The overall survival is on the right, the progression-free survival is on the left, and the median time to progression was not reached for the treatment arm, where it was a high percentage. It was 21 months for those who were observed. And you can see a high percentage of those who were observed developed bone disease or renal failure. And then you can see on the right the overall survival, 94% alive at 3 years for the treatment arm and 80% in the other group. Now, this is a very interesting trial, but it does not mean yet that we should be treating all smoldering myeloma patients, but it's a first step in terms of trying to define which patients should be treated and the best approach to treating these types of patients. So the current guidelines are that a bone marrow biopsy and skeletal survey should be done at presentation. There should be repeat lab tests every 2 to 3 months after presentation, and if stable, every 4 to 6 months for a year, and then every 6 to 12 months if still stable. And the bottom line is treatment's not indicated unless part of a clinical trial, and consider clinical trials for selected patients with the goal to delay or prevent progression to symptomatic myeloma. ECOG currently has a trial that's looking at lenalidomide versus placebo for smoldering myeloma patients. So how do we decide therapy? As I'll show in some other slides, performance status matters more than age. And comorbidities play a lot in terms of the types of therapy you can deliver. Renal failure is very important in that bortezomib-containing regimens are the key to treating patients who present in renal failure. The International Scoring System, or ISS, allows us to determine risk because higher burden disease is associated with a higher ISS score. And I make a big pitch for CD138 selection of the marrow aspirate. 5 years ago, there were very few centers doing this, and now it's becoming more standard. And by CD138 selection, it allows the cytogeneticist to fish for abnormalities that are not seen on metaphase karyotyping. And in particular, we're looking for things such as